Hello my dear curious and studious students of surgery. Myself Dr. Mahesh Chaudhary. I am warm welcoming you in my surgery lecture series. This surgery lecture series contains entire surgery with anesthesia, with radiology, with orthopedic. So stay tuned with us. Let's start our surgery lecture series. Welcome dear students in my surgery lecture number 64, that is the disease of the scrotum and testes. In this lecture we will cover the development of the testes, that is the embryology, descent of the testes, factors which cause descent of the testes, causes of the undescended testes, complications of incomplete descent and its treatment, surgical treatment like orchidopexy and etc., external or anchorage, Kittley thorax operation, Omredens operation, Dennis-Browne's operation, Darter's pouch, orchidectomy, orchidocilioplasty and laparoscopy in undescended testes. All points we will cover in this lecture. Now start with me for the development of the testes, that is the embryology. Testis develops in the lumbar region from the thickened epithelium on the medial side of the mesonephric ridge in the fifth week. This thickened epithelium continues to proliferate, displacing the mesophilus in the dorsolateral direction and forming the projection into the coelomic cavity, which is termed a genital ridge. The interstitial cells of the testes are derived from the mesenchyme but do not become incorporated into the tubules. The cords of the rete testes canalize at the later stage and becomes connected to the mesonephric duct in the 5 to 12 most cephalic of the persisting tubules, and these becomes exceedingly convoluted and form the lobules of the head of the epididymis. The mesonephric ducts become the canal of the epididymis and the ductus deferens of the testes. Now the descent of the testes. At the first testis lies on the dorsum of the abdominal wall. Mesenchymal cells form a cord which extends from this part of the skin, which later forms the scrotum, through the inguinal folds to the lower pole of the testes. This cord later becomes a fibromuscular bundle and is termed the gabernaculum testis. Traverses to site of the future inguinal canal, which is formed around it by the muscles of the abdominal wall as they become differentiated. The testis descends along the path of the gabernaculum, whether or not due to the pull of it. Dear students, here is the anatomy of the testis. You can see on your screen. There is a tunica vaginalis, tunica albuginea, and its septa in the testis is clearly seen. Next is the course of the normal descent of the testis is testis. There is a deep inguinal ring, inguinal canal, and superficial inguinal ring. The scrotum and the course of the testis, that is the suprascrotal undescended testis, the site of the suprascrotal undescended testis, high scrotal undescended testis, and the testis lies in the bottom of the scrotum, that is the normal, is seen by the orange dotted in the screen in the image. This is the image showing the normal course of the testes, that is the abdominal, inguinal and suprascrotal, and the ectopic site of the testes are prepenile, superficial, ectopic, transverse scrotal, the femoral and the perineal site of the cryptorchidism is clearly seen in this image. Now this text image diagram showing the human gabernacular apparatus and the testicular descents. There is a clear-cut anatomy showing the first difference: conjoint tendon, cremaster muscles and inguinal ligament, the pubic symphysis, the mesentery, transversus abdominis muscles, internus oblique muscles, inguinal ligament, cremaster muscles and the scrotal wall, gabernaculum, mesenchyme and separation zone is clearly seen in this image. Now a fold peritoneum protrudes. We are discussing about the descent of the testes and continuing. A fold peritoneum protrudes down the inguinal canal along with the testes, forming the processus vaginalis. The lower pole of the testis is kept in position with the deep inguinal ring by the gabernaculum until the 7th month. Suddenly the testis passes through the inguinal canal and gains the scrotum. As it descends, it is necessarily accompanied by its peritoneal coverings by the fold of the peritoneum from the adjoining peritoneum from the iliac fossa, which is drawn down as the processus vaginalis, as also its blood vessels and nerve supply. The peritoneal coverings of the testis, which represent the distal end of the processus vaginalis and into which the testis projects in turn is termed tunica vaginalis testis. The part of the processus vaginalis which is associated with the spermatic cord in the scrotum and in the inguinal canal normally becomes obliterated. The facial coverings of the testis and spermatic cord, including the cremaster, are developed from the surrounding structures as the testis descend. Now there is a timetable of testicular descent. In the lumbar region, it is in the 2nd month of the fetal life, and in the iliac fossa there is a 3rd month of the fetal life, at the deep inguinal ring till the 7th month, travels the inguinal canal in the end of the 7th month, at the superficial inguinal ring at the latter part of the 7th month and the 8th month, scrotal, its final position, testes enter the scrotum in the 9th month. Now the factor which causes descent of the testes are, first is the shortening of the active contraction of the gabernaculum, increased intra-abdominal pressure, active contraction of the lower fibers of the internal oblique muscles which squeezes the testes through the canal, and the fourth is the higher temperature of the abdominal cavity which is detrimental to spermatogenesis, and fifth is the hormone, especially chorionic gonadotropin from the material circulation help descent of the testes. Now the causes of undescended testes are, first is the abnormality of the gabernaculum testis. Gabernaculum plays a major role in descent of the testes, and abnormality of this structure may result in undescended testes. Second is the intrinsic testicular defect. The testes may be insensitive to gonadotropins and may not act to it. This may lead to undescended testes. Deficient gonadotropic hormonal stimulations, lack of the adequate maternal gonadotropins may be cause of incomplete descent. Fourth is the obstruction due to the adhesions of the testes. Fifth is the short vas deferens. Sixth is the short testicular vessels or pampiniform plexus. And seventh is the imperfectly developed testis interferes with its own descent. Now the next point is the undescended testis. An undescended testis is one which has failed to descend the scrotum and is retained at any point along the normal path or the normal course of its descent. Undescended testis is more common on the right side, that is the 50%. It is less common on the left side, that is the 30%. About 20% cases of the bilateral when both of the testes are absent in the scrotum. The condition is called cryptorchidism, that is the hidden testis. As the right testis descends later than the left testis, undescended testis is more common on the right side. Now the pathology of the undescended testes are, first point is the growth of the testes. It is clear now that the scrotal temperature is at least 1% centigrade cooler than the abdominal temperature. Proper development of the spermatogenic tubules cannot take place in the abdominal cavity. As a result, the spermatogenic tubules are of diminished size and fewer spermatogenia have been detected in the undescended testes in the boys at about 6 years of age. After puberty, the difference is obvious and the undescended testis is much smaller and flabby than the normal intrascrotal testis. The undescended testis is hardly more than half of the size and its intrascrotal counterpart. Dear students, here is the image showing the site of the ectopic undescended testes, that is the abdominal, inguinal and prescrotal region. This is the another image showing the normal descent of the testes, normal course, and where the testis is lying in its course, that is the undescended testis is called intra-abdominal at the point of the internal ring, canaliculi in the canal, inguinal canal, external ring at the point of the external ring, superficial inguinal canal and ectopic in the femoral region. And now the second point of the pathology of the undescended testis is the internal secretory function. Fortunately, the Leydig cells are not affected by body temperature and are therefore usually found in normal numbers in undescended testes. So secondary sex characters appear and endocrinologic cause of the importance is rare in this group. However, in bilateral cryptorchidism, androgen level is diminished to certain extent. Third point is, in the pathology of the undescended testes are, epididymis remains separated from the testes by a long mesorchium, which is a primitive mesogenitally which connects the genital folds to the mesonephros, so torsion of the testes is more common. And the fourth point is, sometimes an undescended testis is associated with a hernial sac. In a series, about 90% of the cases of undescended testes were associated with patent processus vaginalis. And fifth point is, undescended testes may be associated with other urinary tract abnormalities. Sixth point is, the chance of the malignancy is more in undescended testes. Now, the types of the undescended testes are, first is the lumbar testis, complete failure of the descent and the testis remains whereas it was developed. Second type of the undescended testis is the iliac testis, testis remains just deep to the deep inguinal ring. Third is the inguinal, the testis is in the inguinal canal. At the superficial inguinal ring, the testis frequently comes to rest just outside the external inguinal ring. And fifth is the scrotal testis. The testis lies in the upper part of the scrotum. It is often a retractile testis due to the contraction of the overactive cremastic muscle. In this case, the scrotal sac is of the normal size, the testis is also of normal size. The testis can also be brought down to the scrotum. Now the clinical features. History. The age. Undescended testes are usually noticed in children but are occasionally not noticed until adolescent or even adult life. Symptoms. Obviously, absence of one or both testes from the scrotum is the commonest presenting symptom. In fact, the child or the parents first notice that the scrotum is not developed rather than the absence of the testes within it. Occasionally, the patient present in the adult life with infertility, though secondary sex characteristics are usually normal. In the small proportion of the cases, patient presents with the indirect inguinal hernia, that is the swelling in the groin, along with the undescended testes. Now the physical examination. An incomplete descended testis should be anywhere on the line of the normal descent, that is at the neck of the scrotum, just outside of the superficial inguinal ring, in the inguinal canal, or deep to the deep inguinal ring. The testis is only palpable when it is at or outside the superficial inguinal ring. When the testis is within the inguinal canal, it is hardly palpable at the soft testis of the early life is submerged in the non-resisting floor of the inguinal canal and covered by the tendinous aponeuroses of external oblique. If the testis is not palpable, one can press firmly along the line of the inguinal canal to see if there is a tender area, a point where testicular sensation is evoked. Next point of the physical examination is it must be remembered that the undescended testis is often associated with indirect inguinal hernia, and one should always examine for the presence of such hernia. Next point is occasionally one may feel a lump in the line of the testicular descent in its course, and there is an empty scrotum, particularly in adult. The risk of the malignancy is an incompletely descended testis is about 50 times more than in the descended testis. Now the complication of the incomplete descent, that is the torsion of the testis. Second is the epididymo arcuatis is an incompletely descended testis, often gives rise to difficulty in diagnosis, but absence of testes in the scrotum of the corresponding side should arouse suspicion. And the third is the atrophy. An incompletely descended testis is smaller than the normally descended testis. Fourth is the pain. A testis situated in the inguinal canal is often liable to trauma and gives rise to the pain in the groin. Next point is the sterility. In bilateral cases, this may be seen. Malignancy 50 times more than of normally descended testis. Such malignancy is more commonly in abdominal testis rather than inguinal testis. Seminoma is more common in such malignancies in the abdominal type of the undescended testes. Now the treatment. The first is the hormonal therapy. The only indication for hormone treatment is when the surgeon is not sure whether the case is one of erectile testes or not. This should not be used as a routine treatment for incompletely undescended testes. Second point is the bilateral incomplete descended testes associated with hypogenitalism and obesity. This is the treatment of choice when there is a more chance of getting an almost normal testes if orchidopexy is performed before 6 years of age. The hormone mostly used is this chorionic gonadotropin in the dose of the 5000 international unit intramuscularly daily for 3 to 5 days. It may be given in another doses of the pregnil, that is the chorionic gonadotropin extracted from the placenta, which is given 1000 international unit twice a week until the testis descends. If the child refuses to accept the injections, methyl testosterone 5 mg per day may be given by mouth for 1 month. Dear students, here is the image showing the technique of the elongation of the spermatic cord in case of undescended testes. Shows the most common position of the undescended testes. Diagram B and C shows the dissection of the testes along with the spermatic cord. Diagram D shows the technique of the adoption of the straight path of the testicular vessels, and the spermatic cord are bring down to the testes to the scrotum. This is the typical picture showing operation of the orchidopexy. Now the surgical treatment in the undescended testes is the orchidopexy. The main principle of operation is the lengthening of the spermatic cord and the retaining the testes in the scrotum. The types of the orchidopexy are: the first is the external anchorage. The simplest method of the fixing of the testes is in its scrotal bed is to pass a stitch through the tunica albuginea at the lower pole of the testes and to bring this out through the bottom of the scrotum to anchor it to the skin of the inner side of the thigh. By tying it over a piece of the gauze, the stitch is kept in position for not less than 3 weeks must be stayed there. Ketley thorax operation. The testis is brought out through the bottom of the scrotum and is placed in the subcutaneous tissue of the inner side of the thigh, where it is secured by stitching to the fascia lata of the thigh. The wound in the thigh is closed. A second operation is performed at about 4 months later than the first one. Dear students, here is the operation of the orchidopexy. There is the lengthening of the spermatic cord done. Retaining of the testis in the scrotum is the next stage. This is the laparoscopic view of the abdominal undescended testis is clearly seen, and this is the text image showing the method of the orchidopexy diagram A showing the external anchorage, B showing the Omredan operations, and third is the dartos pouch, which is under the scrotal skin and outside of the testis. Now the Omredan's operation, the undescended testis is brought out through a small opening in the median septum of the scrotum to lie with its fellow in the opposite compartment. And Dennis-Browne operation, the neck of the scrotum is narrowed with a purse string, catgut suture, and the testis is anchored with an absorbable suture which passes through the scrotal skin to be anchored to the skin on the medial aspect of the thigh. The suture is kept in position for 2 to 3 weeks. Next operation type is the dartos pouch. A pouch is made between the dartos muscle and the scrotal skin. The incompletely descended testis is brought down to the corresponding compartment of the scrotum and is pushed through an opening in the dartos muscle into the dartos pouch. The opening in the dartos muscles is closed by the catgut sutures. Dear students, here is a typical picture of the forming of the dartos pouch, that is the outside of the dartos muscles and under the skin of the scrotum. Here is another image showing the complete mobilization of the spermatic cord and the testes, the ligated patent processus vaginalis, skeletonization of the cord, then the formation of the dartos pouch and the placement of the testes in the dartos pouch is clearly seen in the lower one image. Now the two-stage operation, sometimes the spermatic cord cannot be sufficiently lengthened to bring the testis into the scrotum. In this case, after this stage of the mobilization, the testis is anchored with a non-absorbable suture. 6 months later, further mobilization is attempted, and in this case, it may be possible to lengthen the cord further and the testis may be brought down to the scrotum. The testis is retained in the scrotum by one of the above methods. Now, this is the types of the orchidopexy. Now the orchidectomy, it is only advocated when the opposite testis is normal. The indication are after puberty, when the incompletely descended testis cannot be brought down to the scrotum. And third is the orchidocelluloplasty. This means the abdominal replacement of the testis. This is only indicated when the other testis has been removed the previously and these testis cannot be brought down to the scrotum. This operation is justified on 2 grounds. Orchidocelluloplasty, it preserves internal secretion of the testis, and second is that the testis is protected from the trauma. For this, the orchidocelluloplasty is to be done. And next is the laparoscopy in undescended testes. Dear students, here is the image. You can see there is a 5 and 10. These are the size of the port which is inserted in the abdomen for the orchidopexy. Laparoscopic undescended testis operation shows the port sizes in the millimeters and position of the port descended for the treatment of the cryptorchid testis. Here is the image showing forming the dartos pouch. The next image is the 3-port procedure of laparoscopic for undescended testes. This is the laparoscopic view. The method now at hand to locate non-palpable undescended testes. The laparoscopy through a small holes is definitely quite helpful to detect the undescended testes. Access is made into the abdominal cavity. The retroperitoneal area of the inguinal ligament are inspected by the laparoscope. If a reasonable size testicle is identified and it is decided to proceed to orchidopexy, is the due course, the spermatic cord vessels are divided between ligatures and 6 months later the orchidopexy may be performed. Dear students, you can watch a good video on YouTube of orchidopexy, laparoscopic orchidopexy, Omredan's operation, Dennis-Browne's operation and dartos pouch operation, 2-stage operation, orchidectomy, orchidocelluloplasty and laparoscopic for the undescended testes are available on the YouTube. You can refer there. Here is the end of our surgery lecture number 64, that is the diseases of the scrotum and the testes. Thank you students.